Hello, everyone. I'm thrilled to welcome you all to this year's annual Refugee Mental Health Stakeholder Workshop. My name is Samantha Strasser, and I'm the project coordinator for this webinar at the Research Program on Children in Adversity at the Boston College School of Social Work. It has been an absolute privilege collaborating with the Boston Children's Hospital's Trauma and Community Resilience Center to orchestrate this amazing event. Thank you for joining us today as we delve into the theme of integrating and uplifting individuals and communities with lived experience into refugee and immigrant mental health service, innovation, and delivery. While we wish we could convene in person, this virtual setting allows us to welcome attendees from all corners of the United States. This webinar is a platform to amplify the voices of policy experts and community health workers with lived experience that are deeply engaged in reshaping the landscape of refugee resettlement and mental health in the United States. Earlier today, you should have received a welcome packet via email to facilitate networking both today and in the future with our esteemed panelists and the dedicated webinar planning team, all united by a shared passion for improving the well-being of refugees. As participants continue to join us on Zoom, we'll kick things off with an engaging icebreaker activity through a poll, which we'll be launching shortly. Your responses to the poll are completely anonymous, and we will only share summarized information. Before diving into our agenda, a quick note: this event will be recorded. Our schedule today begins with the first 10 minutes dedicated to Zoom arrival and our icebreaker activity. We'll then transition to opening remarks from Dr. Jeff Winter and Caroline Diltz, followed by our two panels, starting with our Policy and Systems panel, followed by a 15-minute Q&A session after each panel. During the panels, we encourage you to post questions for the following Q&A in the chat. However, if you want to submit questions more privately, feel free to use the Q&A function where only the speakers and facilitators can view your questions. Following today's discussion, I'll compile a webinar summary and resources packet, including responses to any unanswered questions, which will be distributed to all attendees in the coming weeks. After our second panel, we'll engage in a brief shareback session and gather takeaways using a collaborative tool called Padlet. And then finally, we'll conclude with a summary and closing remarks. And with that, I will hand it over to Dr. Jeff Winter.
Hi, folks. Thanks so much for being here today. We're thrilled for this year's annual Refugee Mental Health Stakeholder meeting. To start things off, and again, I'm Dr. Jeff Winter from our team at Boston Children's Hospital. 3 icebreakers, 2 fun, silly ones, and 1 about your professional role. So you'll be able to put these into the poll. These are anonymous. First one is, what's the best way to relax after a long day? Is it reading a book, going on a walk, watching your favorite show, or dance party in your living room? And again, these are your own perspective. There's no right or wrong. The second one is, what superpower would you like to have? Flight, super speed, invisibility, or reading minds? And then third, what industry or lens will you use for approaching today's stakeholder meeting? So this is essentially your professional role or identity: mental health provider, policymaker, researcher, academic, social service, or something else. And so you'll see the poll questions come up, and take your attempt at those questions. Again, no right or wrongs, just trying to see who's here and just to open up the space a little bit. We'll give this about 45 seconds or a minute, and then we'll go into some comments for myself and then my colleague Caroline. Okay, so right now it looks like going on a walk is our high contender. We'll see how that evolves. In terms of the superpower, looks like flight is also kind of the top contender. And in terms of professional role, we've got social service and mental health provider. Wow, so this is awesome. So we have a nice range across all of these areas. So I'll give it another maybe 20 seconds for folks to fill stuff in. We've got over 100 respondents. Okay, over 125 respondents now. All right, cool. So we're at over 130. So why don't I read out the polls? I'll end the poll in about 10 seconds. All right, so we've got, so for the 2 winning categories for the what's the best way to relax after a long day, we've got 40% coming in on going on a walk, 13% reading a book, 38% watching a favorite show, and 9% dance party in your living room. For superpower, we've got 40% for flight, and then 20% for invisibility and reading minds, and about 10% for super speed. And then for our provider, or for our professional role, We have a nice range across. We have 30% of folks in the audience are mental health providers, 4% are policymakers, 9% are identified as academics, 41% social service, and 17% as something else. And you can see these results right here. And again, we really appreciate everyone taking the time to be here today. We've done this for a number of years and are really excited to connect with you all. So we can move on to our comments about the TCRC. Wonderful. So as I mentioned, I'm Jeff Winter. I'm a psychologist in our program at Boston Children's Hospital, and I'm representing our team. And our group is dedicated to understanding and promoting the healthy adjustment of youth and families who've experienced adversity. And we do this work across partnering with communities and service systems, building prevention and intervention programs, conducting research, and developing resources to assist families and service providers. And refugee and immigrant mental health is a team sport. I feel so lucky to have worked for almost the past 7 years on an amazing team with folks of diverse refugee, racial and ethnic backgrounds and professional experiences and generational influences. I'm here just as one person representing this full team. And so today we'll be speaking primarily about our refugee and immigrant work, but our group is also deeply engaged in multidisciplinary models of violence prevention and programs in global health. And so I'm just going to briefly highlight a couple of key goals in our current NCTSN SAMHSA funded Category 2 grant, which dovetails really beautifully with a lot of the work in today's stakeholder meeting. It's one of the mechanisms that supports it as well. So first, if you're familiar with our program, you can go to the previous slide. So first, if you're familiar with our program, you're likely familiar with trauma systems therapy for refugees, which is a systems-oriented, phase-based trauma and culture responsive psychoservices program for refugee and immigrant youth and families. And we've been working on this program for many years. The primary goal in our current program and grant is really around the wide-scale dissemination across the United States. And we're incredibly lucky that more than 14 programs in the United States are currently implementing trauma systems therapy for refugees in close consultation with our team here at Boston Children's Hospital. Many of the providers, cultural brokers, and leaders of that program are in the audience today. So thanks all for being here and for your continued partnership as we try to serve kids and families. That across these programs, we're so proud and excited that we're able to serve kids and families of an incredibly diverse background. On the left, you'll see some of the countries, sort of the countries of origin in which kids and families are coming from or have experienced migration from. And we're able to support these families coming from, again, all corners of the world. In addition to working on trauma systems therapy for refugees, our program is dedicated to providing national expertise through training, consultation, and education. We've run a best practices series for working with refugee and immigrant youth across multiple years. In our first year, focused on the lens of mental health providers. In the second year, focused on in-person support for law enforcement professionals. And now this year, we're working primarily with school-based providers and educators. That webinar series is currently ongoing. If you're interested, please reach out to us and you can register. And third, in order to support a model that is for communities, we seek to engage the voices of folks doing that work directly in their community. And in order to do that, we've collaborated with local, regional, and national stakeholders through building of a TSDR National Advisory Board. And so this has been an advisory board that meets virtually multiple times a year to support the development and dissemination of TSDR. We have a TSDR Implementation Science and Practice Advisory Board, which is made up of providers and program leaders and cultural brokers. And we also have a community advisory board specifically, which sits within that ISPAB to really elevate the voices of cultural brokers and ethnic community leaders. And we're so grateful to work with all of you and many of you in this work. If you have questions, please reach out to our program if you're interested in connecting, learning more, partnering with us. And thank you for your time and attention today. And with that, I'll pass it over to my colleague, Caroline from Boston College.
Thank you, Jeff. I'm Caroline Diltz. I'm the program manager for our refugee research portfolio here at the Boston College Research Program on Children and Adversity, or the RPCA. Our program focuses on identifying factors that contribute to risk and resilience in children's, families, and communities facing adversity globally. So we contribute to developing an evidence base on intervention strategies to help close that implementation gap, as well as support development of high quality and effective programs and policies in low resource settings, which includes the U.S., including the refugee and newcomer communities in the U.S. We have a great team right now working on several projects led by the director of the RPCA, Dr. Teresa Betancourt. We have developed strong partnerships with our amazing collaborators at resettlement agencies in Maine, Massachusetts, and Michigan, and we hope to continue to grow our network. The RPCA has a longstanding programs working with former child soldiers based in Sierra Leone, where we've been working on a 20-year-long intergenerational study of war-affected youth into adulthood, where we are currently working on the 5th wave of data to understand the effects of trauma on offspring. This intergenerational study is the first known effort in sub-Saharan Africa to look at the intergenerational impacts of war. We also developed from the findings of the longitudinal study in Sierra Leone, the Youth Readiness Intervention, or the YRI, which aims to support healthy youth development, functioning, and support emotional regulation. The YRI has been adapted across cultures and communities, including Colombia, and we are currently looking at the longitudinal impact of that intervention. Some of our other current research is in Rwanda. We focus on family-based prevention study that aims to reduce violence and support early childhood development through Shugura Muryango, or the Family Strengthening Intervention, which was developed in the early 2000s. And this study specifically has informed the work we do with refugees in the US. The program in Rwanda has expanded to over 10,000 families and has demonstrated long-lasting effects for children, families, and communities. And as for our US-based work, our refugee program adapted the Family Strengthening Intervention from Shugura Muryango. So it's the FSIR, or Family Strengthening Intervention for Refugees, which I'll describe now a little bit more in detail. Okay, so this work began with Somali Bantu and Bhutanese refugees in the early 2000s through NIH-funded programs. It's a family-based mental health promotion and prevention program for school-age children aged 7 to 17. We use a brief strengths-based approach, and we try to recognize and build on existing family strengths to enhance resilience. It's conducted using a manualized protocol, which is delivered by interventionists who are trained individuals who themselves come from that cultural group that they are serving. It is usually done in weekly meetings between the family and the interventionist. As mentioned before, it was first developed and pilot tested with Somali Bantu and Bhutanese communities in New England. And during COVID, we also conducted a hybrid type 2 effectiveness implementation study. Following the fall of the Afghan government and evacuation in August 2021, our team worked on a cultural adaptation for Afghan families, which is done to great success and piloted in Maine. We were then able to partner with Global Michigan, the State Refugee Health Department's office in the state of Michigan, to start implementation in that state. And in order to obtain sustainability with the FSIR, we began exploring the development of a digital tool to accompany interventionists as they deliver the intervention. So funded by internal grants at Boston College, we were able to conduct user interface and experience testing and co-design groups to create a digital app which can be used by the 3 cultures that the FSI is currently adapted for. It includes features such as animated videos to increase engagement with families, specifically children, and we're currently pilot testing this application in Maine. Lastly, we also have several projects in partnership with Switchboard, which is a division of the International Rescue Committee funded by ORR, and the development of a digital application. So our program previously partnered with Switchboard to conduct a needs assessment of resettled Afghan families in Boston and Worcester to learn more about the specific problems faced by the community, as well as learning more about the protective resources and strengths. So through qualitative interviews, we were able to identify mental health terminology in the local languages of Dari and Pashto. We will then be testing the measures with resettled Afghan youth and their caregivers to ensure a culturally validated toolkit that providers can utilize in the future. Also funded by Switchboard, we're similarly to our previous project assessing the strengths and challenges of unaccompanied Afghan minor youth in resettlement. Along with the research, we're working with Switchboard to develop educational materials available for refugee service providers, which includes webinars and downloadable resources. So our team continues to grow in its efforts for the resettled communities, and our goal is to continue to disseminate the FSIR to more states who've shown interest. We're looking to establish a solid training model with a seed team of trainers, and hopefully the digital application will also help in these efforts. And as the sociopolitical climate of the world continues to change, we hope to culturally adapt the intervention for more incoming groups. So thank you all for allowing me the space to share more about our program, and I hope that you all enjoy the panels that we have presenting today. I will hand it over to Tim Kelly, who will be moderating our first panel discussion. Tim Kelly is a senior program specialist for the U.S. Office of Refugee Resettlement, Division of Refugee Health. He manages the Services for Survivors of Torture grant program and consults on refugee mental health initiatives. He's a certified trainer at the Benson Henry Institute for Mind-Body Medicine. Tim has managed programs for refugees and immigrants since 1992. He's a licensed clinical social worker with an MSW from the University of New Hampshire and an MA from Boston College.
Thank you, Carolyn. Good to be with all of you today. As Carolyn mentioned, my name is Tim Kelly, and for the first panel, we'll hear from 4 speakers on the policy and systems panel. I'm excited to introduce to you Dr. Alejandro Aleo Mendez, Dr. Sarah Kimball, patient Baraka, and Dr. Sarah Polk, who is filling in for Dr. Kiara Alvarez, who was not able to be with us today. So welcome to our panelists. I'll first provide a brief bio for each speaker, and for their full bios, you can reference the welcome packet. So first, Dr. Alejandro Oleo Mendez is a Jesuit priest from the West Coast province in the U.S. He specializes in analyzing the impact of humanitarian aid on migration dynamics in Mexico. And his research in collaboration with institutions like Harvard and Tufts University, Jesuit Refugee Service, and the Jesuit Latin American Network with migrants focuses on human rights, well-being, inequality, and migration. Currently, he's investigating migrants' digital practices and perceived needs among stranded asylum seekers along the Mexican-U.S. border. And our second panelist is Dr. Sarah Kimball. She's a board-certified internist and assistant professor at Chubanian and Abadisian School of Medicine with expertise in immigration-informed medical care. And as the director of the Immigrant and Refugee Health Center at Boston Medical Center, she pioneers comprehensive healthcare solutions for immigrant communities. And Dr. Kimball's passion lies in teaching social justice and advocacy, reflecting in her roles as an associate editor at the Journal of Migration and Minority Health and treasurer of the Society of Refugee Health Providers. Our third panelist is patient Baraka, a former refugee from the Democratic Republic of Congo and a graduate of Grand Valley State University. He's dedicated to supporting the mental health and well-being of refugee communities, and through his work as a behavioral health practitioner, patient develops culturally appropriate interventions and family-based programs to facilitate the smooth integration of refugees into U.S. society. And he collaborates with diverse partners at the state level to implement and evaluate mental health programs, ensuring early intervention and access to resources. And patient is also using his career success to inspire other refugees and immigrants to dream big, believe in themselves, develop resilience, thrive despite adversity, and develop successful goals and objectives here in the U.S. And our final panelist, Dr. Sarah Polk, is a primary care pediatrician and medical director of Yard 56 Pediatrics. She's an associate professor of pediatrics at the Johns Hopkins School of Medicine. Her overall research interest is optimizing primary care as a means of addressing racial, ethnic health disparities with a particular focus on early childhood obesity prevention and mental health care. And she established and directs the Center for Salud Health and Opportunity for Latin, Centro SOL. The mission of Centro SOL is to promote equity in health and opportunity for Latin by advocating clinical care, research, education, and advocacy at Johns Hopkins and beyond in active partnership with our Latin neighbors. So those are our distinguished panelists, and we're gonna move right into the questions. We'll have a rotation with a different person starting in their response to the question. So let's start with Dr. Kimball. And the first question for all of our panelists has to do with the shortage of professional mental health workers, which exacerbates treatment gap for displaced populations. And the question is, how do you think policy should be designed to facilitate collaboration and coordination between community health workers and professional mental health providers to ensure that community health workers can effectively complement and enhance the capacity of existing mental health systems? And a related question is, what examples of successful partnerships between community health workers and professional mental health providers do you think can help inform these policy initiatives? So start with Dr. Kimball.
Yeah, thank you so much. And I'm delighted to be here with such distinguished colleagues. You know, it's no surprise to anyone here that our current, I would say mostly payment models, but also healthcare structures really are wildly inadequate when it comes to supporting the needs of immigrant and refugee populations. And in addition to the shortage of providers, you know, our system requires people to come to us for the most part. And we've made some strides using telemedicine, but our models are not focused on emic healing solutions. They're not really generally great for populations who move. And I feel very strongly that we're missing opportunities to include other care team members, particularly community health workers, in really creative solutions to try and get more mental health support for our migrant populations. The one example I'll point to that is work that came out of our team, not work that I have been personally responsible for, but some wonderful teammates, is that in our clinic in Boston, we have seen a tremendous number of new arrivals who are pregnant persons and often in kind of late stages of pregnancy showing up for prenatal care. And our team was really finding that they weren't able to meet the social needs or the mental health needs of that population with our current health model. And so they have developed a really fantastic group prenatal care model based on centering pregnancy, which some of you may be familiar with, is a model for group prenatal care. But what they realized is they needed community health workers as a part of those groups, because the groups were both for psychoeducation, for mental health support, but they were also finding that people needed community support. And they needed to know who they could call when they went to the hospital, and who might take care of their other child when they were in the hospital and needed, you know, and delivering. And so what we found was that by having an interprofessional team of community health workers, mental health providers, but then also our immigration legal navigator, we were kind of pulling in all of the expertise to do group care. We were much better able to meet the needs of this population. And in my core, I really believe that a lot of the magic of it was around community building. It was around taking populations who were feeling isolated and not yet learned how our system works, and allowing their generative creativity to inform each other. And so I really think, again, when we look at the policy level, the only reason we were able to do that was because you know, there was a grant from the state that allowed for group wellness visits. So we need to be looking at the policies that facilitate this kind of more creative community-based mental health provision. The other thing is these groups weren't solely billed as mental health visits. They were group wellness visits for prenatal care. And so again, that focuses on one population, but it was a particularly valuable time to be bringing folks together and saying, hey, you're having this shared experience of, starting a family or building your family, growing your family in a new country. What are the supports you need? And some of that was kind of classic mental health psychoeducation, but a lot of it was social supports and networks.
Thank you very much, Dr. Kimball, as an excellent example to illustrate not only the need, but creative ways to address it. Let's go to our next panelist, Dr. Alejandro.
Yes, thank you. I think that in terms of policies, I think we usually have kind of like an issue of what we call the implementation gap. So the policy is usually designed in a certain way, and the problem is, or the challenges rely on how do we make practice or put in place the systems that will implement those policies. I think in regard of what will help or how can we contribute to a better implementation of policies has to do with creating interdisciplinary teams. And in a way, understanding that those policies will be helpful. Now, in regard to the cultural diversity of the responses that we need to address, I think it is important to understand that we need to have a very important understanding of what culture is. We cannot be able to address every culture. We don't have the background in a way to address the culture of any need. So there's a very important element in which we need to have a basic literacy of culture. That means that we as mental health workers, we need to learn. We need to be accepting of the incoming populations, know a little bit of the background, know a little bit of the things that we need to expect from them. And that includes maybe understanding of their history of living. That may be also understanding where do they find resources? So how do they cope with life? Because even people are coping with life even before coming to seek for services. How people navigate system, how people manage. And then another thing that is very important in terms of the cultural understanding of how we approach this is really just to be open to learn from them. The clients that we work with, or the people that approach our services, are the best resource to help us understand the different needs that they may have. An example of how we do it or how things happen at the border. At the border, probably the majority of the people who are stranded, for example, in Mexico, are from Latin America. And one of the biggest challenges has been to serve the Haitian population. The Haitian population is kind of like a population that becomes vulnerable among vulnerable people. So there has been a strong need to bridge not only language, but also culture around practices of care of children, food, because like shelters provide basic needs or attend the basic needs, but also they need to be sensitive to the things that people say that they need. So this understanding of what are the needs from different people, it's very important to understand culturally diverse groups. And once they are allowed to enter into the United States to seek asylum, one of the most important things is how do we accompany these kind of populations with language issues, with trying to figure it out, new environments, how do we accompany them from their strengths, from their best way, and probably support groups are a great source of information for them to form leaders or to identify leaders within those communities that we can train for things that the community may need so that they could be kind of like resources to go. Also access to information that it's not only official, but it's also accessible to the population in a way that it's simple, that it's people can manage, that is understandable for people. That is very important. And different agencies do it in different ways. One example is Casa Alitas in Nogales, who receives in Tucson, who receives asylum seekers as soon as they enter. They kind of have a quick training to support them as they transition in their final destinations. Same organization, Kino Border Initiative in Nogales, they accompany groups. They have developed this model of accompaniment groups, especially they are working out in Phoenix, in Denver, and in Chicago. And they accompany these small groups that they are trying to become resources or go to places so people can find resources and information to navigate a very complicated landscape to access services, to apply for asylum, to access lawyers. And in a way, the communities become the sources of information, or the communities become the go-to place to engage other people who are of recent arrival. So it is a challenge. We need to acknowledge that we cannot address everybody's needs, but we need to partner then with those who have the cultural responses or the cultural knowledge to address the needs of the different populations that arrive into our communities. So partnerships are a key element in this.
Very much. Thank you very much, Dr. Alejandro. And some very, again, clear examples of the, significant needs among Haitians along the Mexican border. So let's move to the third panelist, Patient Baraka. Welcome, Patient.
Thank you very much. And I just want to say, a very good, well-spoken, Dr. Sarah and Dr. Leandro regarding this first, issue that, we are addressing. From my perspective as somebody who has been interacting with refugee over more than 15 years, I think there is a piece of the puzzle we are missing at this point. First, I think we need to understand that, from the ecosystem of refugee resettlement, there is a gap. That ecosystem has a gap. Why? Because we are trying to define the need of refugee, not by themselves, by us. The resettlement agency has to define what they need. The donors has the requirement. The state has its own requirement, and the refugee found themselves in a way that, they don't have any leverage to negotiate what are their needs. And the second issue is we do not help refugees be involved in addressing those needs. We need to develop a framework where we are consulting with refugees what they believe will be the best way to address their need, rather than you and me in office defining what are the needs and how we're going to address the issue. So that's the first question I think we need to be able to understand. The second issue in regard to this question, I think we need to develop what I call a multi-level collaboration between resettlement agency and agency providing services, social services agencies. Instead of working in solo and duplicate resources, misuse resources, if they work in collaboration, in partnership, in coalition as one body, sharing resources, sharing best evidence, best model to address mental health and other issues, I believe on both ends, we have success from the refugee perspective and from the agency perspective. And the third thing is we need to be able to look into the refugee coming. Refugees who are coming to America are not only coming with issues and drugs, and as some people said, coming to rape people. There are people who are coming with skills, and creativity, inventiveness. There are people who are coming with diplomas, highly educated, and we could utilize those people and say, hey, there is an opportunity to solve your own community, and this is an opportunity, is a paying job. How will you be involved as a community health worker in your community, addressing those, mental health issue and other cultural barrier? I think if we can go back and look into the refugee population, try to pick the best and those who are empowered, equipped already, and provide them a path to certification, a path to learning, a path to getting into the body of a community health worker, I believe those will be able to really help us address 90% of the issues. As Dr. Leandro said, we cannot address all the issues, but at least from a cultural and a refugee perspective, they should be able to have a great understanding how to help their members, the community members, really live a healthy and a productive life. Those are the three things I wanted to share. Thank you.
Thank you very much, Patient, for your perspective. And I'm going to move right to Sarah Polk for her response.
Thank you. I see a lot of my professional experience in what's been shared by my three colleagues, and I'd like to share a couple of practical examples from my work. So again, I'm working in Baltimore, Maryland. I serve Latino immigrant families. Baltimore has a lot in common with other new emerging cities, and that we have a mismatch between the population who in need of services and the people that we can employ on the basis of their legal status, especially as I work with a large academic institution. So we are growing the future workforce, but we have really a tiny base of people that we can employ who are bilingual in English and Spanish and have the cultural knowledge and experience that we're really looking for. And then there's the issue of financing. So we have run a couple of programs to try to get around these various challenges. And also to say that I am also a big believer in groups. There is good data around the benefit, the therapeutic benefit of being in community with other people with whom you have shared experience. And I have sort of observed how powerful that can be, especially for people that, while they have a lot in common and they share the same community, even here, they live in a lot of isolation. In Baltimore City, some of that is driven by community level violence. And depending on the state of immigration rhetoric is driven by a desire not to have any encounters with official personnel of any kind. So one example is a program called Mothers and Babies, largely run out of Northwestern University in Chicago. So we were finding in pediatrics that we were witnessing challenges to children that really were secondary to their mother's challenge, experiencing depression or other mental health concerns, but the mothers, no access to insurance, and without the financial resources to pay for care, and we really don't have therapists available to serve them anyway. And so we've capitalized on community health workers that have roles in schools to run we're trying it virtually. We've also offered it in person, and both modes have been shown to be acceptable. So it's a postpartum depression prevention intervention, and it's delivered by a community health worker who has employed through the school system to support 0 to 5-year-olds. So it takes advantage of a worker within the system who has a reasonable job and is trained and supervised, and then we bring in the mental health expertise to support the implementation of the program and to provide any additional skills that person might need. But the community health worker is coming with the linguistic and cultural awareness. And then the groups are really designed for the members to have a lot of conversation, for it to be a very active conversation. So the facilitators are really often there just to provide guidance and to provide some specific skills, but there's a lot of peer learning that happens as part of the program. So it's just an example of, it's obviously highly specific, and we just need lots more of lots of things, but locally it's a workaround that addresses, gets us an intervention that's culturally and linguistically appropriate, brings people together, and is preventive in nature, and is a way to provide services to people who are otherwise ineligible. So thank you.
Thank you very much, Dr. Polk. I appreciate your comments and highlighting some of the key, ways to address this gap, including peer learning and community building and focusing on prevention. So at this point, we're going to move to Q&A because although our panelists would have a lot more to offer, we want to give you an opportunity to ask questions of them. And so let me start by going to the questions that have been submitted currently. And the first one is, how do you ensure language access for the services that are being provided? And I know there's different ways to do that. I'm just curious, maybe focusing on what you think the best way is and the most practical as well. And let's go in the same order. So starting with Dr. Kimball. And you don't have to respond. If you have a response, please share it.
Sure. Yeah. So I'll say I feel really spoiled in this regard because our hospital has a very robust interpreter services division. And because we take federal and state money, our hospital is required to have interpreter services. I think it's 186 languages available through our language line. BMC used all of those languages last year, including a few that were much less frequently used languages that needed, planning and preparation. So I feel a little bit spoiled by being in that healthcare system. But I feel very strongly that we need to expand that right to language access outside of the healthcare system. There are some nascent apps and programs that help give language access rights to people in the community. And that's really where I think we need to move, because, we see in healthcare that people come to us with concerns that may impact their health, but are not directly health related, because it's the one place they know that they can get an interpreter. And so, I think that we see that right to interpretation is such a benefit. And I would love to see us think about how other sectors also uphold that same value.
I think like in low resource settings, like for example, the border or the immediate aftermath of people entering the United States, there may be not such easy access to translators. So there are different ways to bridge that. And of course, the interventions it depends on the kind of interventions that we will be talking about. But often, like to provide basic services, you rely on Google Translate. And now that we have kind of like phones or these apps that allow you to translate immediately, those are, I will say, tools that help you bridge or overcome those immediate gap deficits or those deficits in terms of language availability. It's very important that if there's kind of like certain interventions that have materials that could be helpful, I think we can invest on having those materials translated in the languages that are needed for the populations that we work with. So translation of materials is important. Apps are another way to do it. And probably I would say also identifying some stakeholders in those settings that can help pivot immediate needs of translation. when someone cannot translate, there would be someone among the Haitian population. That's the population that I'm thinking. People who are coming either from Chile may be able to speak Spanish fluently. They are Haitians that moved to Chile and they are now migrating, seeking asylum in the US, but they would be able to fluently speak to a certain degree Spanish, and they would be able to bridge some deficits with the kind of work. But again, having available materials for this kind of population, that would be also very helpful.
So yes, in regard to translation, I believe Michigan is setting a very good example. The state of Michigan, we are the pioneer in this domain, in this regard. So the Office of Global Michigan, where I work, which is part of the Department for Labor and Equal Opportunity, if you Google, you will see that we have made it mandatory that every agency working in a state, business or hospital, you name it, has to provide interpretation services to anybody needing interpretation. And not only for psychiatric hospital, mental health, behavioral health, but also we understand that, social services where people will go seek for housing, apply for food, needing transportation. And we made it mandatory, and this has been really mark of the governor of Michigan, Gretchen Whitmer, and not only we have an officer who's in charge of language access and literacy. That's how a position is named. But also we make sure all the material, if you have a books, you have a I'm talking about flies, has to be translated into different languages. So for people have access to this material, not only in English, they can read it in other languages, Swahili, French, Arabics, Pashwa, Dari, Afghan. So this is something we are working on. It's a work on the beginning stage, but I think the state of Michigan is setting the bar very high. And we require even interpretation, even it's gonna be remote telehealth, we require interpretation, and the service provider has to pay for the interpretation so that the client does not have to pay the bill, because that became another hiccup or another barrier to accessing services if you impose somebody to bring an interpreter, and we know it's very expensive services. Thank you.
I just put a couple of things in the chat. In Maryland, we were seeing a lot of kids refused mental health care on the basis of even just their parents' language sometimes. So I think it's important in local communities to be testing those systems, to do some secret shopper. And we work to try to bring some attention to this. And then in Maryland, some legislation passed this year to have counties be able to apply for funding to reimburse interpreter services. I think there are a lot of providers who want to do the right thing, and sometimes they claim financial hardship, but they also just claim that they don't actually know how to, they don't have a language plan for their agency, and they don't know how to connect to an interpreter. So I think there's more work to be done on teaching people how to do that. And then I do believe in accountability. And I also come back to what Patient has said about, harnessing the strength of the community where, these members that we're welcoming into our community, and to take advantage of the language skills that they bring, and think about how to integrate them into service provision. I do think it's important to have to test language abilities, especially in healthcare settings. We see a lot of over-claiming of language skills, and bad interpretation is dangerous. So that needs to be prevented.
Excellent. Thank you very much. I'm going to next combine a couple of questions here because we're running a little bit short on time, and I want to make sure each of you get a chance to respond to it. So the first question is regarding partnerships with those with lived experience. How do you ensure lived experience as part of program design? And then a related question is that, are there models of community-led mental health that incorporate the community voice and empowerment or leadership development that address the gap that patient was referring to? Let's see. Yeah. So again, speaking about lived experience, how do you incorporate that into the program design? And secondly, how do you incorporate the community voice and empowerment or leadership development to bridge that gap, to address that gap in programs? And let's go in the same order. So Dr. Kimball.
I'll be quite brief so everyone has a moment to respond, but I would say we make that part of our hiring. And so we have really explicitly said that lived experience is something we prioritize when looking for hiring on our team. The challenge that we sometimes see is kind of like getting folks trained and also supporting them once they're on the job. We see this in particular. We're also seeing a large Haitian population, and making sure that our Haitian staff members are supported in doing the work that is much more personal for them at work. What do we need to put into place to make that sustainable? I also will say there's lots of great training models. I participate in a training that was looking at training resettled refugees to be research partners. And so I think a lot of the times I see approaches where you're just trying to focus on the hiring piece without thinking about the training and empowerment side of it, and thinking about support once we have folks in our teams who carry that lived experience and are sharing it. What do we need to do to create a culture that actually facilitates them being able to share that wisdom and to have it be heard by systems of power that are not always inclined to that? And I'll stop there, even though there's a lot more to say, so everyone has a moment.
Yeah, probably I will emphasize two things, and I will say a little bit more of the community mental health models and how to include people. We just need to ask people, make sure that we ask people. I mean, it may be an obvious thing, but I think we cannot overstate the obvious. If we really want to include the community voice, we need to sit down with the people. And once we kind of get the voice of the people, we need to represent in a way, or to include those voices in the grants that we make, on the funding, the kind of funding that we look for, in the kind of the materials that we produce, because those are the things that matter. And also we need to understand, also to contextualize why, for example, if there's something surprising in what people are saying, what are the structural factors that lead to that voice or to that issue emerging? So I think it's basic. It's basic. It may be obvious, but just make sure that you really sit down and have members of the community participating or exposing or representing the voices that you want to hear.
Thank you to both panelists, because this just, speak loud to me as a former refugee from the Democratic Republic of Congo. And you can understand when I came to the US, I did not speak any English because I was only Swahili, French, Lingala, some of them, the language spoken over there. But the adjustment itself to be able to speak a very good English, that's what I call a milestone, for refugees. So you need to understand that there is a need to utilize people who have already broke the ceiling, people who are able to really understand the refugee pipeline from a refugee perspective and provide them with resources. And that's what there is a gap. When we want to ask for resources, the requirement becomes so high that we are left behind. And those who are providing services, they do not understand really how we became refugee and what are the needs. So that's a problem. The second, I believe in Michigan, what we are doing, we are encouraging, these local behavioral providers, CMH, community mental health, and the other psychiatric hospital to be able to be trained to understand how people become refugee and how the power of the trauma, the interplay of the trauma when the people come to America, how it affects their lives. They may know know that, all those best intervention, but those interventions do not work for refugee because refugee, first, they don't know and they don't understand the language of mental health. It's a taboo. And second, there is a bias and, stigma around it. So how do you break it? Take a refugee, train them, provide them certification so they can become behavioral health themselves. Just recruit among refugee one of the best. If there is a scholarship, if we have to open a system of a scholarship to give them a pathway to, certification, absolutely. I think that's where we need to put the resources, rather than saying that, there is a need to expand capacity. There's need to expand capacity. Every day that's a song we sing, but we don't want to put the resources into the people that are able to address the issue from themselves. Thank you.
Thank you, patient. And if Sarah, if you'd like to comment, we got about 30 seconds.
Yeah, thank you. So we use a two-tiered system of advisory boards for any intervention that we're going to launch in the community. So we have an ongoing advisory board that's available for consultation, comprised of Spanish-speaking immigrant adults, and those are all conducted in Spanish. And then for any project that's going to be more involved, we create an advisory board for that project specifically. I do think there's a little bit of a tension between needing the voice of the community and the ability to pay people for that time. Obviously, there may be people that want to volunteer, but I'm a little wary of how much we ask for and how can we pay these people for their time and their expertise. So that's the approach that we've taken here. But I do think that the community voice is certainly critical.
Excellent. Thank you all for this very engaging discussion. And we had other questions, which I think that we will share the panelists' responses to those questions in the after webinar summary. So we will capture that input and share it with you. Just a moment to highlight a few brief takeaways before we move to the next panel. I think one takeaway is that it's imperative that we address the critical shortage of mental health workers serving displaced populations, and do that by fostering collaborative efforts between community health workers and professional mental health providers. Second takeaway is that we draw upon successful partnerships between community health workers and mental health providers, such as joint training initiatives and integrated referral networks, so that we can develop policies and frameworks that enhance the capacity of existing refugee mental health systems. And then third, we must prioritize the implementation of culturally responsive practices in mental health service delivery, ensuring that policies support the provision of culturally tailored interventions and practices. So thank you very much for your comments and your examples of where these types of practices are taking place. Very encouraging for the field. So again, I'd like to thank Dr. Aleo Mendez, Dr. Kimball, patient, and Dr. Polk. So now it's my pleasure to introduce Soweit Johannes, who'll be moderating the next panel. Soweit is a clinical research assistant working at the Trauma and Community Resilience Center. She graduated from the University of Michigan with a BS in Biology, Health, and Society, and a BS in African and Afro-American Studies, along with extensive, just lost my place here, 1 second. Yes, extensive volunteer work, working with refugee communities. She's worked to organize a global mental health conference and designed to connect those with lived experience around the world and galvanize individuals to make a change in their own communities. So Soweit hopes to pursue a PhD in clinical psychology and aims to collaborate with marginalized communities to co-create and adapt effective and culturally responsive interventions. So welcome, Soweit.
Thank you so much, Tim, and thank you all for being here. My name is Soweit, and for the second panel, we will hear from three speakers on the Community and Providers panel. I'm so excited to introduce Baitullah Hamidi, Marie-Christine Sembizi, and Freshta Diab. Baitullah Hamidi is a visiting scholar at the University of Rochester's Susan B. Anthony Center and previously served as an educator in Kabul University's Communication and Journalism Department in Afghanistan. He was also a freelance multimedia journalist. Baitullah relocated to the US after the Taliban takeover of Kabul, and since then has been actively involved in humanitarian efforts, particularly in supporting Afghan refugees in Western New York. Additionally, Baitullah maintains ongoing connections with students and educators in Afghanistan. And then for Marie-Christine, with extensive experience in behavioral health, social services, and refugee resettlement, Marie-Christine has dedicated her career to serving marginalized communities. As a lead cultural broker and children care coordinator, she brings 5 years of expertise in supporting refugees and new immigrants through cultural brokering and case management. Prior to her work in the US, Marie-Christine spent 5 years as an assistant researcher in Rwanda, contributing to research, teaching, and consultancy in GIS applications. Holding a master's degree in environment and development from the University of KwaZulu-Natal, South Africa, Marie-Christine continues to make impactful contributions to the field of humanitarian aid and community development. And lastly, but never not the least, Freshta, founder of FT Translation Services, is a dedicated advocate for social justice and cultural competency, drawing from her Afghan heritage and upbringing in New York City. With expertise in family intervention and a focus on marginalized refugee communities, particularly of South and Central Asian and Middle Eastern descent, Freshta Diab has made significant strides in domestic violence prevention and refugee rights, recognized for her impactful work, including pro bono assistance to Afghan refugees and co-authoring a handbook on culturally appropriate services. Freshta's commitment to inclusivity and understanding continues to shape her vision for a more unified society. So now as we get into the questions for the panel, the first one that I want to focus on, from your all perspective as a community health worker, how do you think community health workers effectively enhance and complement the existing mental health system? Additionally, can you provide insights or examples of successful partnerships between community health workers and all their other mental health providers that have contributed to improved service delivery for displaced populations, and how these collaborative efforts can inform future policy development? Excuse me. Christine, I'll kick it off to you to start.
Thank you so much, and thank you everyone for having me. It is a great pleasure to be on this panel. So I'm going to answer this question from a perspective of a cultural broker and a care coordinator, which is my role. And this role is embedded in a TSTR model, which is a model we are using on the program I'm working on in Maine, supporting immigrants and refugee population. Well, throughout my work, I found things that really have been really helpful. Number one, is to bridge the cultural and the language gap in mental health service delivery. Even when the access to language line is provided, I found it helpful to be present to make sure that I can attend to the cultural gap and language gap. As you know, many of the terminology, mental health terminology, they don't necessarily translate in the languages spoken by the population we serve. And the other thing is to explore different ways to raise awareness and education on mental health. This is a problem among the population. We serve mental health is a taboo, and it's really not well known. And it's really important to educate the people we work with. And I used different ways, family meeting sessions, during the visit with the PCP, just doing some advocacy and make sure that providers, most of the one who are really trusted by the community we work with, like the medical doctors, the PCP, they can provide some education around mental health. And also I found that it helps to form some partnership with trusted institution, like I mentioned, the PCP office, but also the school and the local community organizations to ensure that those people can work together to support the families. Talking about successful partnership, from my personal work, I found very helpful partnering with the clinician who work with my clients. And this is really part of the model we use. We organize team meetings, regular team meetings, and family meetings, and that is really helpful. Because when I have regular check-ins with the clinician, she gets to understand some of the cultural background or cultural differences that impacting maybe the engagement, or what are some of the needs that are really taking primacy over the mental health service delivery. And that has been really helpful. Another successful partnership was done through the PCP office, being present at the visit and making sure that the provider, the doctor that the family trusts can provide some messages around the diagnosis, around explain the referral, explain what is some of the challenges the child is going through. That has been really helpful. And also, I help to educate the providers as well, to provide that cultural understanding and those cultural differences between the systems. When it comes to inform the future policy development, I would say that through grant writing, thinking about incorporating cultural brokering, cultural brokers, I think it can make a difference in terms of engagement and reducing the stigma. Thank you.
Thank you so much, Christine. Those are great points, including, thinking about the cultural gap, even if language translation is available, thinking about how you can bridge the gap in cultural understanding, not just with the families, but with your partnerships with clinicians, schools, and other providers. I wanted to toss the question over to you, Baitullah, to see if you have any thoughts on them.
Yeah, thank you, Suchi. I agree with Christine shared. It's so important to think about working with new arrived refugees who, of course, been through tremendous trauma, and then they are struggling with understanding the US system at the same time and the culture. Culture is one thing to be struggle with, and then struggling with the US system, which is so complicated because of all the insurance system with all the bureaucracy it's involved for assisting a very small services. You need to struggle with a lots of things. I remember working with one of the mental health clinician, and she mentioned it's not enough to have good intention while you're working with refugees. It's more important to know the refugees beyond the good intention and work with them. And that part could be only provided by people who know the culture already. You might, in near future, we might have all these AI system who can exactly and very appropriately translate language for you, and then people will think so we don't need an interpreter anymore. But with mental health and overall physical, even physical health, it's so important to know the culture and the practice that are already embedded in the population that you're serving. It's sometimes a very small metaphor that refugees are used. And speaking for the Afghan community, we do not have mental health institution the way it exists in the US and Afghanistan. But when it comes to dealing with mental health issues, we have a lot of spirituality, we have a lot of literature that's working, and we have a lot of metaphor. Even this most of the symptoms of mental health are explained through metaphors. With the name we have, we don't have it the way it's named in English language. We have metaphoric names for it. Parishani is for anxiety, and I don't know, Jigarhoon is for being sad. So all these metaphoric names, if you don't know the back culture, it will be problematic. Another thing is when you're working with a new arrived community, refugee community, uh, it's important for you to have someone who who's you're hiring from the community, so they might have a shared culture, but most of the people for community workers are not considering that that person from the same community might be suffering the same way their community is suffering. So it's so important to take care of that part of the problem, to take care of your uh, culture brokers, your community liaisons, and your interpreters. I heard in the first panel that it's so difficult to find people who can serve as a culture broker. I believe one of the reasons is that language interpret it's now it became a business to have a language service company, but they're paying the interpreter who are the bone of this business minimum wage. I have worked minimum wage working as a interpreter and health system. That's why I know so many people in Afghan community, they will be properly speaking English, Pashtun, three languages at the same time, but they won't want to work because they're not paying enough. Or they want to work only in the legal system because the legal system pay more, but not the health system. It's damaging me more than I will receive. So that's so important to not only know about the community, but about the workers that you are hiring.
Thank you, Baitullah. That's really incredible. I think in your response, thinking about, thinking about fair pay, recognizing that the people who are the backbone of this of these companies, of these organizations, and really compensating them for what you say, putting your money where your mouth is in that way. So I wanted to give you, Freshta, an opportunity to think about, I know Baitullah kind of touched on both the first question and the second question about, challenges and barriers to helping displaced populations. And before we move to the third question, I wanted to give you some space to talk about those things.
Yeah, sure. So thank you so much for including me with this esteemed group today. I think a few things. First of all, I think Dr. Kimball had mentioned earlier in the conversation the holistic approach. It's so incredibly important for refugee communities, especially that they come from collective societies, to, when healing these individuals, make sure community is involved, the place of worship is involved, social and cultural elements are taken into consideration, even when it comes to collaboration, to be so strategic in those collaborations. For example, community members will trust a place of worship or a cleric over what a governmental agency may or may not say, right? And this comes from PTSD, this comes from trust issues. And, an example of this in my line of work is the Virginia Department of Behavioral Health was putting together some mental health workshops on emotional resiliency and on mental health awareness. And they had reached out to me, and I said, we've done this before at places like community centers or more Western settings, libraries, and we've had maybe 30, 40 participants if we were lucky. I said, this time, let's go ahead and try a place of worship. So we had it in a mosque. And guess what? We had over 300 participants. Why? Because folks are going to feel comfortable in a place that they're normally going to. People understand the language, people understand the culture. And as a matter of fact, we've taken it a step further and we started to train our clerics in domestic violence, for example, because one of the things that comes from these, PTSD, anger management, all of this trauma that folks have gone through the migration has been a lot of domestic violence issues, whether it's between spouses, whether it's between parent and child. And I think that training folks that are in these other arenas of the culture and making it a holistic approach is something that we found to be very productive. Also, I know that we didn't talk too much, or we started to talk a little bit about policy, but since that was an element that I wanted to discuss, it's very important to include, and this is something that I battled with when I was working on the Safe Haven in one of the military bases where the Afghans were being placed. I was a cultural advisor, and it was very difficult for us to have a voice when it came to making decisions, when it came to policy, right? Especially, I'm a board member of the Afghan American Foundation, and we had a campaign on the Afghan Adjustment Act, AAA, right? Listening to folks, giving them a seat at the table, allowing them to take part in making decisions for their own people is key when it comes to policy. The problem is when folks lack cultural competency or cultural awareness, then they will make decisions that will unfortunately sometimes be to the detriment of folks. I know earlier one of my lovely colleagues had mentioned errors in interpretation. Errors in interpretation can really create detrimental situations. Dire consequences come from a word being misinterpreted, and I've seen it happen. Incarceration, wrongful imprisonment happens. Folks get wrong diagnoses for mental health disorders, for behavioral health issues. These are things that we definitely want to come in play. Also, the last thing I'll mention about the cultural competency component is one of the projects that I've worked with actually with the IRC and UC Davis has been to actually serve as a cultural validator for mental health assessments and evaluations. Why? Because looking at a mental health evaluation or a test or an assessment, looking at the questions, looking at the way those questions are asked can be highly offensive in our culture, right? And if you don't have that cultural competency and you don't have that awareness, then instead of being able to get honest and truthful answers, then unfortunately people will be misdiagnosed, and that can lead to very difficult consequences.
Really great points about cultural competency and how that really touches on all aspects, right? Not just community engagement, but assessment of patients, and also, in the clinical setting, what that means for like wrong translations and such. So I wanted to focus on the one last question before we head into the Q&A. And I'd love to get all three of you guys' input. So as individuals with lived experience, your role as community health workers holds immense value in providing peer support and fostering trust and rapport within refugee and immigrant communities. In what ways have you been able to connect with the families that you work with? How do you navigate the delicate balance between drawing upon your own experiences to connect with families that you work with while maintaining professional boundaries, ensuring quality care. So I'll pass it over to you, Christine, to start.
Yeah, thank you so much. We connect with families in different ways. Like I mentioned, my role as I'm a cultural broker, at the same time, I'm a care coordinator or case manager. So I have different ways to connect with families when I'm connecting them to resources, to providers, when I'm facilitating the meetings with schools, with clinicians. Those are different ways to connect with providers, with families. So the part of the question you want us to know, to explain how we navigate the delicate balance between drawing on our own experience and to maintain the professional boundaries and stuff. Yeah, to me, I found practicing cultural humility has been really helpful to me. And this is a concept that is embedded in the model we use. Here's the challenge. When you work as a cultural broker, you're part of the community, sometimes you can be considered that you know everything. You can solve everything. Families will believe that, providers will believe that, they will think you have a magic to use to make sure that the family can engage. And you too, myself, I can, to some extent, start believing that, oh, I know everything. And there is that power imbalance between the family I serve and me being able to speak English, me able, knowledgeable about the systems, a little bit about the systems and the resources. That can be challenging. So I found that practicing the concept of cultural humility, recognizing my own biases, understanding that between me and the family I serve, there is that power imbalance, and also try to be curious as much as I can. And in case I have, I encounter an ethical dilemma, I always like to seek consultation from my supervisor, from the team members. That's one of the things I have been practicing.
Thank you so much, Christine. Baitula, I'll hand it over to you.
Yeah, thank you, Sudhir. One thing that balances, especially as I said, when we work as a community members, we meet the community beyond our work. So maybe from time to time, because we're part of that community. At least in my case, it was I'm part of the Afghan community in the area I'm living. So I work for them in the area that they're being served. So I will meet them sometimes in some community gatherings and all, and people will approach to you and ask about different things. You're meeting families during the official appointment they have for to receive the services, but it's happening beyond that too. And of course, people will ask you because you are the only connection for them between the service receiver and the service provider, and you speak their language, you connect to their culture and all. So the practice of setting boundary is getting really difficult. What helped me was to practice and learn self-care from time to time. There was a time that I did not know much about the self-care practices, but luckily at time I got a supervisor who will sit with me and teach me how to take care of myself. She told me, we give you the separate office phone so you can practice. uh, of course, the data and information, everything is important, but also when you are out of office, so you're not working, so turn off the phone. So you are not receiving phone messages and emails, and you are not held responsible for answering. Um, Also explaining to the people at the same time. what are your limitation? What are the limitation in the system? What are the limitation and the service provide with the service providers? Me and my colleagues would love to help people, but there might be only so much that we can do. So explain that to them the way that you think will not be offensive, the way that you think that will not be brutal, but it could help them. So they can look for themselves and find other ways. Another thing, uh, providing service should not be only about assisting people, especially with vulnerable communities. I believe it should be about empowering them. So from time to time, help them and assist them or on the way to empower them. So one time you help them with something, next time they should be able to do that thing for themselves. For example, if someone is asking for, I don't know, reaching out to some service provider, you could teach them or work with them so they can learn and do that. That might be in the health provider system or something else, other service, social service provider system. I have been through this and that had helped me a lot.
Thank you so
And
much. Thank you. I really appreciate it. And now, Freshta, please.
Thank you. So in August 2021, I received a phone call I'll never forget. Hey, Farishta, a plane is coming in with over 1,000 Afghans to a military base. What are we going to do, right? So the first thing, I got together with a few community leaders. We had a discussion and we decided we can't do this alone. We created the New Jersey Coalition for Afghan Refugees. We gathered any and every organization that we knew under one umbrella. And we met every other day, then once a week, then once a month. And we were able to, we did the local coalition, and then there was a national coalition of Afghan organizations throughout the United States that was meeting once a week, every Monday night. And we were constantly in communication on how we're going to be able to overcome these challenges. There is, I know Dr. Mendez had mentioned it before, there is a power behind capacity building, behind coalition building. But cultural competency trainings, I know that my colleague had just mentioned about, coming together and having cultural humility, right? Also, in line with that, providing cultural competency trainings to these agencies and to these folks from learned people who are subject matter experts. People need to feel heard. They need to feel understood. And they can't do that unless they have the knowledge, unless they understand where these folks are coming from. Share within reason. I'm very happy to share within reason. For example, my family member was diagnosed with depression. 60% of this country has depression. If you had diabetes, would you take your insulin? Of course you would. Antidepressant works the same way. My relative did it, and now they're feeling so much better, right? And then they'll take a step back and say, okay, she's also from my culture, right? Somebody in her family went through this. There is a power behind relatability and being human. Always human first. We have to always have that approach above and beyond what our titles are, what our status is, what our roles are. We want folks to feel like they can understand and they can relate to us, that there's no power dynamic, that we're all here, right? A colleague of mine, we teach a behavioral health interpretation course, and she always says practice makes progress, right? We're not looking for perfection. We're looking to keep practicing what we're doing in order to be able to get better. Training is the key. We train each other, we learn from one another so we can ensure quality care. Two things for us as providers. One, there's a power of saying no. You have to know when to say no. And when you could say, this is what I can do for you, and this is what I cannot. Because when you don't do that, then you burn out and you're good to no one, including yourself or your family or your colleagues or your community, right? And you can't give from an empty cup, of course. There's another example. I think folks, when they're in survival mode, they really will try to ask for whatever they can get, right? So even if that's like, I'm at the clinic, I'm talking to you about my issues, my problems. Can you give me a ride home? Is it on your way? you can be very politely say, you know, I thank you so much. I'm so sorry. I'm unfortunately, due to the constraints of my profession, I won't be able to give you a ride, but I can help you get a ride. Let's see if access a ride, right? And this is going back to the second question where we have these challenges. We have monetary challenges. We have budget challenges. The fiscal issues that we have is one of the biggest challenges when it comes to the refugee and immigrant community, the different legal statuses and what we are able to fund and what we are not able to fund, right? And for the Afghan community, especially, the funds are drying out, right? Where folks are moving on. So there's a different range of issues that are need to be met at this point.
Thank you all so much for your comprehensive and really thoughtful answers to these questions. And so now I'll shift over to the Q&A. There's been some activity in the chat, and so I would love to start with one that I think all three of you have kind of touched on in kind of separate ways, but really thinking about how mental health and mental illness is really quite stigmatized in communities, and how you all work in addressing those issues through your respective roles. Why don't we start with you, Christine?
Well, that's really a good question. There is a big problem of stigma around mental health. And it starts with the simple things with the language. Even translating some of the language can lead into a big stigma, while when you bring the culture, the language, addressing the language gap, like a cultural broker, you try to explain, well, they are referring to this. Let's say where I grew up, mental health problem, it refers to an acute mental health situation, kind of like schizophrenia, those kind of things. So the moment you tell a parent at school that the child has been diagnosed with mental health, then they are going to be overwhelmed because they believe the child is normal, is not running around, is not that. So addressing even those simple words related conceptualization things through the language translation and cultural brokering, explaining the symptoms in a way makes sense, because sometimes the translation, exact translation is not there, is not available, that can make a difference. And I think Fletcher talked about that. Engaging families in social groups through community organization, church, where they can discuss, they can get some experience, and from the peer experience from other members of the community to share what they are going through. So people start thinking, okay, I'm not the only one. Oh, this and that has received the services and it worked. And then people start slowly overcoming the stigma issue. But it's a work in progress. There is a very huge problem around mental health stigma.
Thank you, Christine. Baitula, I'd love to toss it over to you next.
Thank you. Actually, this is one of the things that I have been always struggling with Afghan community. As I said, we do not have mental health institution the way it is built in US, and also we have these extreme notions of mental health in our society. So when you tell someone that I remember I was interpreting to one of the Afghan refugees time that the doctor wanted them to be referred to a mental health facility for counseling, and her answer was, "I'm not crazy. Tell my doctor I just have problems sleeping at the night. I'm not crazy. That's it." So when you have that kind of reaction from the community members, it's so difficult. It's getting difficult because doctors and clinicians are always talking this very defined language, the professional language, which are mostly academic jargons, which have its notion. But when you're talking with someone who just arrived from a village in Afghanistan, and for them, mental health mean, quote unquote, being crazy, bridging that gap is difficult. What I have practiced and had helped me a lot is to focus on the symptoms, not on the terms. Uh, I will tell the person, as you explained, you have difficulty sleeping night at the night, or you are worried all the time. This is how you explain you are thinking about these things. So meeting someone professional and sitting with them and talking about this will help you this way. It's just okay. We all been through this thing. For me, especially sharing my personal experience, since I'm a new refugee, I'm being through this thing. I remember when we were in that refugee camps, this military camps in Qatar or here in the United States. I saw things like this way, and now it's affecting me. But here I help, or a family member seeked help, and now they're feeling better. As Parishta earlier explained about if you have diabetes, you will take your insulin. These kind of practice had helped me a lot. Another thing is to know the notion, cultural notion of things. And to adjust that fear first. When you get experience in this thing, you know, okay, I think that reaction will be this way from my community member. So you adjust that fear first. It's not, you're not crazy. It's not that you're in big danger, but just to overcome these symptoms, you need to take these steps. We will help you to go through this step. Here are the things that we can do. And that had helped me a lot, and also helped the community member to understand the practice easily.
Thank you, Aitula. Thank you. Freshta, I was wondering if you might be able to tuck into this through a slightly different lens. I know you mentioned community engagement in the mosques in your community. And so thinking about what kind of efforts are being made to recruit religious leaders addressing mental health issues, and also thinking about using community leaders' religion as a way to reduce social isolation to improve mental health.
Absolutely. That's a great point. We use a lot of preventative measures, meaning, gathering people in a place of worship where people feel safe, but explaining you don't necessarily have to be one-on-one with the clinician. Once you've already, you're on your way to diagnosis. Preventative care is very important in this country, something we lack back home. So having 300 plus people in a room and saying to them, how many of you feel this way? How many of you feel isolated? And then everybody looks around the room and 300 people feel the same. That's a very, very different approach. And I have to say, I have a different experience because 50% of the population of Afghanistan is under 35. So when I was on the safe havens, I actually had a very easy time. I think the hope behind the message is that folks are starting to destigmatize, these notions, because a lot of the younger folks were coming to me and saying, Firisha, can I schedule a session with you? Can we take some time to talk? Because I think I'm depressed or I think I'm anxious. I don't think this is normal. So I actually have a very different experience. And that actually makes me feel very hopeful that things are changing and that the younger generation are starting to realize that, hey, I did go through something. I always say, the first thing I always say is PTSD is exactly what it is, a normal reaction to something very abnormal that happened to you. And that's a game changer because then folks understand that life everywhere is not war. But if that's all you know, and then you come into a completely different scene, that's not something that's going to be forgotten, right? You're going to carry that with the rest of your life. So definitely, everything that my colleagues mentioned, especially when it comes to breaking down the illnesses in a way in which, just asking them, if you had hypertension, would you not check your blood pressure? It's the same thing. It's a pill a day, if the person needs medication, of course, or if the person feels that if they need talk therapy, for example. We always say, you don't have, your family's not here. You're not living with 20 plus people in a compound. Now it's you and just your nuclear family. So how about you talk to me? Consider me your older sister from here on in. You just want to change, like Baitullah said, you just want to change the vernacular. You want to change the terminology to make it more coherent to folks.
Thank you all so much for your thoughtful responses. I mean, we covered such a plethora of different, really important topics, thinking about this idea that even though the language translation is there, there's still a cultural gap, and thinking about, building strategic collaborations, as Freshna mentioned, like a multidisciplinary team, and really involving folks from a lot of different sectors to make sure that people are receiving like holistic, comprehensive care. And then this idea, I think Christine mentioned, like cultural humility, being able to be humble in your own experiences and thinking, I'm one person, and even like one person, a cultural broker may not have all of the cultural knowledge in one culture, and thinking about this idea of relatability, as Freshla mentioned, speaking as one person to another person, breaking down kind of stigmas from a interpersonal relationship point of view, and kind of bringing this idea of translation not just in the one word sense, but creating, as Baitula mentioned, the background of the language, and bringing kind of a cultural context to your work. So thank you all so much again for your thoughts, and to Christine, Baitula, and Freshla for this time. And I'll pass it on to Jeff now, who will be introducing the Padlet activity.
Thanks, Sweet, and to our amazing panelists, both in the previous panel and this panel. I was buzzing with excitement and enthusiasm for your comments. I feel like there was such beautiful synergy and innovation in the comments you were sharing. So really excited again for all the content here to be documented. Again, a lot of this will be sent back around to folks. If you're furiously taking notes or wanting to make connections, again, please connect, reach out by email, but also a lot of this content will be coming back to you so we can continue to have a really solutions-focused way of moving this content forward. So in order to hear more directly from folks, we're going to be using an online bulletin board tool called Padlet. In order to access that, you'll see a link in the chat, or you can use the QR code to access a document where you can then submit responses to 2 specific questions, and they'll be sharing that back to you. Again, that information will be shared, and then we'll be looking at this now just to hear some of the comments from folks in our community. So the questions that we're asking folks to respond to are, what is something you learned today and feel inspired about? And then the second is, what is something you will carry forward into your practice, and specifically a concrete action? Again, and these will be a way of documenting to share back, and then also for us to see together where folks in our online community now of more than 200 people in this space are connecting. We also have, again, a lot of questions that came through. So if the comments weren't able to be answered in the panel directly, those will be answered in the follow-up email that comes back. So I'll give folks some time to engage with these questions, and then I'll sort of look at some themes and share those out. And again, the link to the Padlet is in the Zoom chat that Samantha just put there. So click on that link, and then you'll see there's a plus button on the bottom of that web page that comes up. So you can't click on this screen that's being shared, but you'll click on the web browser that comes up and then click that plus button. And so I can just read out a couple from our left side. From my left, what is something you learned today and feel inspired by? I learned that the voices of those in the community are underrepresented in current policies and legislature. I learned that there are many resources to help overcome some of these barriers. The importance to provide material support to cultural brokers and community workers. So I understand that to mean making sure that folks are financially supported and sustained in order to do the important work that they're doing, and figuring out both either grant-funded mechanisms or insurance-based ways of supporting folks in their jobs so they can stay in these jobs as opposed to having to leave for a job that pays higher wage. Again, fair compensation for refugees and immigrants who offer their language and cultural skills to serve. And then a couple on the right side that are coming in. What is something you'll carry forward into your practice? The concept of mutual learning is crucial to build lasting partnerships. Again, I think almost every commentator on our panels commented on the essential element of true, genuine partnership, and then doing so in a sustainable, collaborative way, so folks' voices are actually integrated into the work. Gathering larger groups of folks in outreach discussions to, again, Fresh Data made this example of kind of normalizing through community action. We talked about, Dr. Polk mentioned around the value of group-based interventions, and then Fresh Data mentioned these comments around when we normalize in a group setting, we allow for collective healing and again, normalization of challenges, things that are extremely common in our space, including depression and anxiety symptoms or traumatic stress symptoms. Engaging religious leaders and communities within these conversations must be at a root if we're trying to shift attitudes and beliefs. And again, a lot of this is around anchoring around trusted messengers or contexts that are culturally responsive and community engaged, where folks are naturally going, trying to move with that tide, as opposed to trying to use a service system, a traditional hospital setting that may or may not be as effective. If we can scroll down on the Padlet a little bit so we can see some other comments, that'd be great. So the potential for collective healing, again, these sort of collectivistic responses, which again lean towards cultures that are historically collectivistic. We all have a voice, and it's our responsibility to be sure that they're being heard, to be able to be received. Yes, so I think there's the kind of lip service of we care about every voice, and then it's how does a program in a sustainable way support that? Well, we talked about, a number of people mentioned the value of community advisory boards or different types of advisory ecosystems. And again, trying to figure out how do you integrate those voices often, and then how, hopefully as much as possible, they are compensated. So folks are, their work and their wisdom is supported, so it's sustained. If you could scroll down a little bit on the left side, so something you learn and feel inspired by. Yeah, so the value of multidisciplinary teams across the behavioral health ecosystem, and then with legal and law enforcement and faith-based organizations is incredibly valuable, and it's such an important part of community resilience. Even when language barriers are overcome, there are still significant cultural barriers. Exactly. So Baitula made a comment around, even if you maybe have an AI infrastructure for direct translation, there's so much cultural nuance. Maybe AI gets there someday, but for the most part, the human-to-human connection is so valuable, and I think we'll never lose that. And we are humans in human service to each other, both the language, cultural, and interpersonal elements. If you can scroll down a little bit more, and then on the right side too. And then we just got about 1 more minute, and then I'll pass it over to Caroline. So a few more here, different ways of asking questions. Again, focusing on, Baitula mentioned around symptoms. Christine talked about the balance between setting boundaries, personal self-disclosure, and orienting to what people can and can't do to set effective expectations. Right, and you can't overstate the obvious. Again, some of our colleagues on the policy panel were talking about really anchoring to concrete ideas that may seem simple or may seem foundational, but if they're not explicit and put into place, voices are often left out, or people are often left out of systems that are often not designed to support them. Let's see, any other ones that I haven't gotten to? And again, these will all be shared out for folks. And I'll contribute with this other comment. I'll contribute what I have learned by learning and experiencing and connecting with the community to support each other. And then bringing, maybe this is where we can close it, sort of bringing that personal touch to build rapport and trust is essential. And so again, we have these best practice principles that are being illuminated today from so many different voices, from so many parts of the US, from so many different lived experience and professional backgrounds. So grateful that we were able to connect today. I'm going to pass it over to Caroline for our last section. Thanks, everybody.
Thanks, Jeff. Yeah, those are some really great answers. Thank you all for engaging in the Padlet activity. And thank you all, of course, for your questions. And a special thank you to our amazing panelists. With the various examples and experiences shared, we heard some really fantastic insights today from the individuals who work on a policy and a provider level. You know, we learned what systemic changes need to happen to help best support staff with lived experience, as well as the resources and recommendations for addressing the disparities faced in the field. We also heard about some of the challenges experienced by workers with lived experience, such as setting boundaries with clients, overcoming mental health stigma, and ensuring cultural competency in organizations. And we heard from the providers about ways that they demonstrated successful partnerships with mental health providers as well through community engagement and a holistic approach. And again, all of this emphasizing the importance of cultural broker and community health worker roles. So as we wrap up, we want to just acknowledge the support of the National Child Traumatic Stress Network for making this event happen today and supporting these crucial conversations. And most importantly, we want to thank you all for joining us today to discuss this important work. And we hope that you can continue to engage and collaborate with Boston College, Boston Children's Hospital, and NCTSN in the future. If you are wanting to engage further with our team or with the panelists here today, contact information is included in the welcome packet that you should have received. So I will hand it back over to Samantha to just discuss the feedback form that we'll ask you all to complete. Thank you again.
Thank you so much, Caroline, for your insightful closing remarks. I want to extend my appreciation to everyone for their active participation today. Our discussions have truly been enlightening, thanks in large part to our esteemed speakers who generously shared their expertise and experience. I would also like to thank the amazing planning team who helped me orchestrate this event. All of their professional information can be found in the welcome packet as well. As mentioned earlier, please take a moment to fill out the feedback form that I've shared in the chat. Your input is super important and will help us shape future events. If you have any remaining questions for our speakers, feel free to post them in the chat and we'll address them in our follow-up materials, along with a summary of today's discussions and additional resources. We'll also send the recording of today's session to those who RSVP'd, so keep an eye out on your email inboxes for that. And once again, thank you for contributing to making this webinar a success. We appreciate your engagement and look forward to continuing this important dialogue in the future. Until next time, take care and stay well.